Now we'll move on and talk about the urinary tract. At transabdominal ultrasound, often done with a full bladder, I was taught when I was a resident, rule number 1 is to identify the bladder, and that is shown here. I thought that seemed pretty self-obvious. Of course you identify the bladder. It's always the cystic structure that is in the superficial aspect of the scan plane anterior to the uterus. However, it turns out it's actually really important to be sure that that cystic structure is the bladder because other things can sit there. So notice that the bladder's typical shape, unless it's extremely overdistended, is not completely round. Rather, it's often somewhat teardrop-shaped, or as in this case, somewhat pear-shaped. And this is because, although subtle, the uterus will typically have an impression on the posterior wall of the bladder. Not the other way around. The bladder is more impressible than the uterus itself. And you can see that subtle posterior impression on the bladder at the level of the yellow arrow. Now this is important because some ovarian neoplasms are predominantly cystic, and so you may not see any material within these ovarian neoplasms. They may look just like rounded fluid-filled structures. And moreover, the ovary is mobile, and it can interpose itself between the anterior portion of the uterus and the abdominal wall. And so this was initially thought to be the bladder. However, if you look carefully, the uterus is not impressing on the posterior wall of this structure. Rather, it seems like the structure is pushing on the uterus. Now, fortunately, before this was permanently assumed to be the bladder started to fill. And so at that point in time, it became very clear to the person doing the scan that the structure we were seeing was not the bladder, but was actually a cystic mass located anterior to the uterus. And this proved to be a large serous cyst adenoma. In a similar example, we have a structure that was initially thought to be the bladder here, no posterior impression of the uterus on the bladder, and at a different time in the study, though, the patient's bladder actually filled. And now you can see the bladder here. You can see the expected posterior indentation of the uterus on the bladder. And where did the mass go? The mass went up here. The bladder pushed it out of the pelvis, and you can just see the leading edge of this mass on the transabdominal image with the bladder full. So when the question comes up of, is this really the bladder or not, it's important to either fill the bladder or empty the bladder to be sure you have definitive identification of the bladder. In this patient, endovaginal ultrasound was also performed, and although no internal material was seen at transabdominal ultrasound, multiple septations were seen at endovaginal ultrasound. And this mass also proved to be a serous cystadenoma, which seems to be the most common mass to do this simulation of the bladder. Other masses I've seen this with have been very large corpus luteal cysts, as well as dermoids that are very uncomplicated in appearance. Pitfalls also arise from the ureter. When we see a tubular structure in the pelvis and we're doing a gynecologic ultrasound, often the first things we think about are a hydrosalpinx or a dilated blood vessel. But another possibility is a dilated ureter. This particular structure here, which was seen in the left pelvis, was initially thought to be a left hydrosalpinx. However, with further imaging at real-time evaluation, you can see that the structure is actually peristalsing. Peristalsis is not typical of a hydrosalpinx and would bring up the possibility of either a dilated distal ureter or a loop of bowel. And so by following the structure, one can decide whether or not it's ureter or bowel. The ureter is going to rise out of the pelvis eventually, go towards the kidney. Bowel will have a more tortuous appearance if you scan it long enough. And sure enough, when one scanned up in the flanks, there's pelvic cholecystis in this left kidney. The patient has both a dilated upper collecting system as well as a dilated distal ureter, but the right kidney has no pelvic cholecystis. So clues to ureter versus hydrosalpinx include peristalsis of the ureter, and a hydrosalpinx often has partial septations due to mucosal folds. Here is an example of the partial septations in one patient, and these can be all the way around the periphery of a hydrosalpinx, giving you a so-called cogwheel appearance as we see here. We will finish by talking about pitfalls that are specific to endovaginal ultrasound. Now, clearly, if you could only do one ultrasound approach, one would want to do endovaginal ultrasound. The detail it provides allows us to be so much more confident and so much more specific with our diagnoses. But unfortunately, endovaginal ultrasound is not without its limitations. One of the limitations is actually an easy one to get over, so long as one understands it, and that's that image orientation is altered when you compare it with transabdominal ultrasound. So while a fluid level is going to be seen horizontally at transabdominal ultrasound, as we see with the material layering out in this multiloculated endometrioma, and this is a transabdominal image, at endovaginal ultrasound, you can see that the fluid level will be either at a more vertical or a more diagonal orientation, sometimes causing people to not perceive the presence of the fluid level. But more important as a pitfall is that endovaginal ultrasound only provides a limited field of view. And as a result, it's possible to miss pathology high in the pelvis because it's beyond the field of view of the endovaginal probe. It's also possible to incompletely image a large mass, and if you don't image the margins of mass, it's possible to not even perceive the mass exists. Here are some examples. Here we have an endovaginal image of the uterus, and no mass is seen on this image, and no mass was seen during the entire endovaginal scan. However, the transabdominal ultrasound shows a very large mass superior to the uterus, with the uterus being here and the urinary bladder being here. In fact, this mass is so large that it measures 12.7 centimeters, and yet it could not be imaged at all by endovaginal ultrasound because it was beyond the field of view. Here's another example of a mass that was only seen at transabdominal ultrasound and not endovaginal ultrasound, a relatively normal appearance of the uterus at endovaginal ultrasound, but at transabdominal ultrasound, there's a huge mass located immediately superior to the uterus. And this mass can be best imaged by scanning through the abdominal wall because it extends all the way up to the umbilicus, where you can see that it is a solid mass and it has shadows and it's characteristic of a large fundal fibroid. But this fundal fibroid would have been totally missed by endovaginal ultrasound alone. How about incompletely imaging the margins of a large mass? This patient was scanned first at endovaginal ultrasound, and the initial impression of the person doing the scan was things weren't working because they could not see anything. Well, when transabdominal ultrasound was performed, it became clear why specific structures could not be seen. That's because this patient has a large dermoid, and the dermoid at endovaginal ultrasound was much larger than the field of view, so you couldn't see its margins, and it also was attenuating the sound, and as a result, the dermoid could not be perceived. So earlier in the lecture, we saw an example of a dermoid that could only be seen at endovaginal ultrasound, and now we've come full circle, and now we see an example of a dermoid that can only be seen at transabdominal ultrasound. Finally, here's another example of incompletely imaging a large structure. Here's a normal-looking endovaginal ultrasound of the uterus with a mass seen posterior to it. Because the leading edge of this mass was seen, the field of view was markedly increased, the depth was markedly increased, and it was actually possible to see the entirety of this mass, which really wasn't a mass at all, but rather a pelvic kidney. And so with that, I'd like to thank you for your attention today.